Welcome friends, a very good evening. Dr. Anuradha here, your ophthalmology educator at Unacademy. And today we are going to discuss the topic of antiglaucoma drugs. Rather, I have titled it as Mastering Antiglaucoma Drugs. So I'm sure at the end of this session, we'll be masters of antiglaucoma drugs. Okay, so let's start friends. Now, before coming to the antiglaucoma drugs, let's first of all have a quick recap of the dynamics of the aqueous humor and intraocular pressure. Okay, we all know antiglaucoma drugs are the drugs which we are using to control the intraocular pressure in glaucoma. Okay, so what are the dynamics of the aqueous humor? Now, aqueous humor, all of you must be familiar with this diagram. This is your cornea, the sclera, the iris, the interior chamber, pupillary area, posterior chamber, ciliary body. Okay. Now the aqueous is being produced by the ciliary body, ciliary epithelium. Okay. Now this aqueous which is being produced in the posterior chamber through the pupil, it comes into the interior chamber. Okay. Remember, now after the production and flow of the aqueous humor, it has to drain out of the eye. Okay, so the drainage of the aqueous humor has two main pathways. One is your conventional and the second one is your uveoscleral pathway. Okay, so in the conventional pathway, through the trabecular meshwork into the Schlemm's canal, the aqueous humor will drain. Okay, which is the major pathway. Then you have a minor pathway, that is uveoscleral pathway, in which some of the aqueous humor passes over the ciliary body and then it is drained into the suprachoroidal space. Okay, so that is your uveoscleral pathway. Okay, so these are the dynamics. The aqueous humor is being produced continuously in the eye and it is being drained out of the eye. Okay, now if we want to control intraocular pressure, okay, because in glaucoma, one of the important change which is happening is increased intraocular pressure, except for the cases of normal tension glaucoma. Okay, but to control the progression of disease in case of glaucoma, the method which we have in our hand is to control the intraocular pressure. Okay, so modality which we are using is to control the intraocular pressure, in which the anti-glaucoma drugs, they help us. Okay, so what are the ways? Either we can decrease the aqueous production. So if there will be less aqueous produced, intraocular pressure will be controlled. Okay, or we can increase the outflow of the aqueous. Okay, now increasing outflow through the aqueous can be achieved by increasing it through the trabecular meshwork pathway, which is our main pathway, or increasing it through uveoscleral pathway also will help. Okay, so these are the three basic mechanisms through which we can achieve the control of the intraocular pressure. Okay, and this is where our anti-glaucoma drugs, they come into play. Okay, we have number of drugs which act through either one of these pathways to help us achieve a good control of intraocular pressure in a case of glaucoma. Okay, so if we list all these drugs, they can be listed as I have given in this slide. Okay, so number one are your prostaglandin analogs. Okay, prostaglandin or PG analogs. Then are your beta blockers. Okay, the third group is of alpha agonist drugs. The fourth group is of carbonic anhydrase inhibitors. The fifth group is of miotics, okay, or the cholinergic drugs. And the sixth one are your hyperosmotic drugs. Okay, so these are the 6 groups of the drugs which we can make use to control intraocular pressure. Okay, so let's discuss them one by one. Okay, so first of all, we'll be discussing about prostaglandin analogs. Prostaglandin analogs are your first line therapy. Okay, prostaglandin analogs are your first line or drug of the choice when you want to initiate the medical therapy in a patient of glaucoma. Okay, so in today's world, prostaglandin analogs, they are constituting the first line therapy. what is their mechanism of action? Prostaglandin analogs, they act by increasing the uveoscleral outflow. So this is important to remember. What is the mechanism of a particular antiglaucoma drug? Okay, so prostaglandin analogs, they help by increasing the uveoscleral outflow. Okay, so the drugs which are available with us, we have latanoprost, we have travoprost, we have bimatoprost, and the latest one is your tefloprost. Okay, tefloprost is the latest prostaglandin analog which has been available now. Okay, the latest one. Now, prostaglandin topically used, they have got minimal side effects. Okay, if you will compare it them with the other anti-glaucoma drugs, the side effects are quite mild, and they are one of the most efficient drugs to reduce the intraocular pressure. So they bring about good control of the intraocular pressure. Okay, so side effects are mostly local only, that is in the eye. The two which are important from cosmetic purpose are your iris pigmentation and hypertrichosis. Okay, so prostaglandin, they increase the iris pigmentation, so they lead to iris heterochromia. Okay, so if you see, this patient has been using the latanoprost in the right eye. Okay, travoprost in the right eye. So you see, the eye which has been using the prostaglandin has a darker iris as compared to the other eye. So there can be difference in the color of the irides in two eyes, increased pigmentation in the eye in which the prostaglandin is used. Okay, then the second effect is hypertrichosis. Okay, look at this figure there. So again, this patient has been using the prostaglandin analog unilaterally, and if you compare the right eye with the left eye, you can see the eyelashes over here are longer and more dense. Okay, so it makes the eyelashes longer and more dense, which is known as hypertrichosis. Again, this is a typical side effect with the prostaglandin analog. So these two things, they are the people, they are affected by this. But if you say they are more of a cosmetic blemishes, and they are more troublesome when the patient is on unilateral therapy. Okay, because then the difference between the two eyes is more prominent. Okay, then the other important side effect of using prostaglandin analog is, as prostaglandins, you know, are associated with inflammation. Okay, so they are in the body, they are inflammatory mediators. So these topical prostaglandin analogs, when they are used as anti-glaucoma drug, they can cause inflammation in the eye. So they can be associated with anterior uveitis, and they can cause cystoid macular edema. Okay, due to their, you can say, increase in the inflammation. So if the patient is having glaucoma in uveitis, okay, if a patient who has uveitis and glaucoma, so you will not be preferring the prostaglandin analogs. Prostaglandin analogs will not be preferred if there is high pressure in uveitis. And similarly, if there is pre-existing macular edema due to any reason, you will not prefer prostaglandin analogs. Okay, so the things to be remembered about prostaglandin analogs, they are the first line therapy. They are the drug of the choice for initiating the medical therapy. Their mechanism of action is to increase uveoscleral outflow. Okay, so they have mild side effects which are mainly local. Okay, iris pigmentation, hypertrichosis, and they are contraindicated, you can say, in the presence of uveitis or pre-existing macular edema. You will avoid them. Okay, so this is about your prostaglandin analogs. Okay, now we move on to the next group. Which are your beta blockers. Okay, so before the prostaglandins, they came into the picture, beta blockers were, you can say, the mainstay of the therapy in glaucoma. Okay, though now, as I told you, they have been surpassed by the prostaglandin analogs. Okay, but beta blockers, their mechanism of action is, they are what we will call as aqueous suppressants. Okay, they act by decreasing the production of the aqueous humor. Okay, so they are aqueous suppressants. Okay, so the drugs which are available with us: timolol, levobunolol, bitexolol. Now, beta blockers, they can be non-selective beta blockers or they can be selective beta blockers. Okay, so out of these three which are used in the eye, the bitexolol is the selective one. Okay, bitexolol is the selective beta blocker. It is a cardioselective beta blocker, whereas the timolol and levobunolol are non-selective. Okay, so this is important because unfortunately beta blockers, even the topical use of beta blockers, is associated with lot of systemic side effects. Their systemic side effect profile is due to their non-selectiveness. Okay, so the local side effects are very mild, usually dry eye and the superficial punctate keratopathy, but it is their systemic side effects which make them contraindicated in multiple systemic conditions. Their systemic side effects, they include bronchospasm, bradycardia, hypertension. They can cause sleep disorder, they lead to fatigue, they can cause depression also, and they lead to decreased exercise capacity. Okay, so these are the multiple systemic side effects of beta blockers when they are used topically in the eye to control the intraocular pressure. Now, because of these systemic side effects, they are to be avoided in these systemic conditions. Obviously, according to their side effect profile, they'll be contraindicated in congestive heart failure, in second and third degree heart blocks, a patient with bradycardia, a patient with asthma, or chronic obstructive pulmonary disease. So they will not be preferred. The selective beta blocker or the bitexolol can be given in the patients of COPD or asthma, okay, because it is a cardioselective one, but otherwise for the rest of the conditions it needs to be avoided. Okay, so beta blockers are very good IOP reducers. Okay, they are efficient anti-glaucoma drugs. They are aqueous suppressants. Okay, but their systemic side effects are many, as we discussed, and they are contraindicated in congestive heart failure, heart blocks, bradycardia, and chronic obstructive pulmonary disease. Okay, but they can be combined or they can be used in additional drugs to the prostaglandin analogs. Okay, so when we are combining the two anti-glaucomas, so if there are two drugs who have different mechanism of action, then their action becomes additive. Okay, so we can combine the prostaglandin analogs with beta blockers also. Okay, so if a patient is not controlled on the monotherapy, okay, by a single drug, monotherapy means a single drug, then a very good combination is of prostaglandin analogs with beta blockers, because their mechanism of action is different. They increase the uveoscleral outflow, and beta blockers are aqueous suppressants, so they are additive to each other. Okay, so these are the points to be remembered about beta blockers. Coming to the third group, which is your alpha agonist. Okay, alpha agonist, their peculiarity is that their mechanism of action is dual. They have dual mechanism of action. Okay, what is that dual mechanism? That they decrease the aqueous production also, and they increase the uveoscleral outflow. Okay, so they have double action. They are acting by reducing the aqueous production as well as by increasing the uveoscleral outflow. Okay, what are the drugs which are being used clinically as alpha agonist for anti-glaucoma purpose? One is your brimonidine, which is available in 0.2% as well as in 0.1% concentration. The second one is your apraclonidine. Okay, now out of this, apraclonidine is used only for short term. Okay, for example, you did iridotomy or you did capsulotomy and you want to prevent the sudden rise of pressure, because when you are doing these laser procedures, iridotomy or capsulotomy, laser capsulotomy, sometimes there can be sudden spike of intraocular pressure. So for that short-term control of intraocular pressure, epreclonidine is used, because for longer duration it has more side effects, and there is a phenomena known as tachyphylaxis. That is the effect of the epreclonidine wears off with time, you can say. Okay, so the alpha agonist which is used for the longer durations in the clinical practice is your brimonidine. Okay, so what are the side effects of alpha agonist? They are the one which are most commonly responsible for causing allergic conjunctivitis or allergic blepharoconjunctivitis. Okay, so the most common cause of allergic blepharoconjunctivitis in the antiglaucoma group are your alpha agonist. Okay, then they can also cause lid retraction. This is a very peculiar side effects with alpha agonist. Lid retraction, this is more commonly or more prominently seen with epreclonidine than with the brimonidine. Okay, so lid retraction, a very peculiar side effect of alpha agonist, more prominently seen with epreclonidine than with brimonidine. Okay, then they can also lead to cystoid macular edema, and one of the important side effects, systemic side effects of alpha agonist is that they can cause central nervous system depression, CNS depression. Okay, so in this regard, it is important to emphasize over here about brimonidine that especially in children, the brimonidine can cause drowsiness, sedation, and even sleep apnea. Due to the CNS depression, brimonidine can cause sleep apnea in children. So brimonidine is contraindicated in children. This has been your past exam question also. So very important to remember, brimonidine is contraindicated to be used in children. Okay, but another important point about brimonidine is that it is the only antiglaucoma which can be given safely in pregnancy. Okay, so two important points about brimonidine: contraindicated in children due to the risk of CNS depression, sleep apnea, but it is the only antiglaucoma which is considered safe to be given in pregnancy. Okay, so these are the important points about brimonidine or alpha agonist. Double action: decrease the aqueous production, increase the uveoscleral outflow. Okay, most common side effect is of allergic blepharoconjunctivitis. Most serious side effect is of central nervous system depression causing sleep apnea in children, hence contraindicated in children. Okay, okay friends, now we move on to the fourth group of our antiglaucoma drugs, which are your carbonic anhydrase inhibitors. Okay, now carbonic anhydrase inhibitors, they also decrease the aqueous production, okay, by inhibiting the carbonic anhydrase enzyme. Okay, so this enzyme also has a role in the aqueous production. So carbonic anhydrase inhibitors inhibit this enzyme, and they also act as aqueous suppressants. Okay, they also act as aqueous suppressants, right? So in the carbonic anhydrase inhibitors, we have the drugs which can be given systemically as well as, so these are the systemic preparations, and these two are your topical preparations. So we have both the kind of preparations available with us. Okay, systemic one are your acetazolamide and methazolamide. Acetazolamide is the most commonly used. Topical one, they are your dorzolamide and brinzolamide. So your amide, remember carbonic anhydrase are amides. Okay, acetazolamide, dorzolamide, brinzolamide. Okay, now the topical ones, the topical drugs, they have very mild side effect. Okay, they can lead to endothelial decompensation in some patients. Okay, or they can, if they come in the throat, they cause a bitter taste. Okay, so mild side effects with the topical drugs, but your systemic or the oral carbonic anhydrase inhibitors, they have multiple side effects. okay, out of which the most common is your paresthesias. Paresthesias is tingling sensation in the extremities, okay, and this tingling sensation is due to hypokalemia. The use of carbonic anhydrase inhibitors leads to decreased potassium levels causing paresthesias. Then they can cause very commonly gastrointestinal upset. They are sulfonamide, they belong to sulfonamide groups, amides as I told you. So to all the patients who have sulfa allergy, they are contraindicated, okay. Then they can cause renal stones, they can cause metabolic acidosis, they can rarely cause aplastic anemia. So systemic side effects of giving oral carbonic anhydrase inhibitors are to be kept in mind, okay, and they are to be avoided in patients with kidney disease, in patients with sulfa allergy, okay. And then one very interesting side effect of using oral carbonic anhydrase inhibitors is that they can cause ciliary body edema, okay. Your oral acetazolamide can cause edema of the ciliary body. So imagine if there is edema of the ciliary body, that will push the iris in front and it will lead to a secondary angle closure. Secondary angle closure. And if there is angle closure, paradoxically the pressure will increase, isn't it? You are giving oral acetazolamide to decrease the intraocular pressure, but in certain patients it can cause ciliary body edema leading to increased intraocular pressure. So that also is a thing which is to be kept in mind, that in few patients this side effect can happen, okay. So your oral acetazolamide has multiple side effects. The topical ones are very well tolerated, okay, and they are also used as second line drugs. Second lines means when the pressure is not being controlled by the first line drugs. First line drug are your prostaglandin analogs, okay, do remember. Okay, then we come to the group of the miotics or the cholinergic drugs, okay. So miotics or the cholinergic drugs, their mechanism of action is different in primary open angle glaucoma and in angle closure glaucoma. So they can be used in both. In primary open angle glaucoma, they can be used for their effect on increasing the trabecular meshwork outflow, okay. So they increase the outflow of the aqueous through trabecular meshwork. So the only ones which are doing this, okay. So far we talked about prostaglandin analogs. They increased the uveoscleral outflow. We talked about alpha agonist. They also increased the uveoscleral outflow. So they are miotics or cholinergics are the one which are increasing the trabecular meshwork outflow, okay. And they are the drug of the choice to break an attack in acute congestive glaucoma. We know acute congestive glaucoma is a medical emergency. It's a medical emergency in which, due to papillary block, due to dilated pupil, there is markedly increased intraocular pressure. So here miotics, they help to break this papillary block. The pupillary block has happened because pupil is dilated. You put pilocarpine, the pupil is constricted, the pupillary block is released, the aqueous is able to flow from the posterior chamber to the interior chamber and pressure comes down, okay. So that is their mechanism of action in breaking an attack in acute congestive glaucoma, okay. So the drugs which are commonly used are your pilocarpine and not so commonly used your carbachol. So pilocarpine is nowadays the only miotic which is used, okay, and again mostly used to break the attack in acute congestive glaucoma, okay. Now these cholinergics, they have multiple side effects, and these side effects are mostly associated because they will cause ciliary muscle spasm. They are cholinergic drugs. So we have the cholinergic or parasympathetic receptors in the ciliary body. So in ciliary muscles, stimulation or spasm leads to these symptoms, especially the brow ache or the headache, pseudomyopia, okay, formation of iris cyst. There is also increased risk of retinal detachment, okay, increased risk of retinal detachment. So that is a serious side effect which is associated with the prolonged use of these miotics. Okay, then they also lead to shallowing of the interior chamber. Okay, because they pull the iris lens diaphragm forward. Okay, the prolonged use can lead to cataract formation, though this is more with the long acting cholinergics which are nowadays not used, for example your ecothiopate, etc. Okay, so this is with the long acting cholinergics. They also lead to increase in inflammation in the eye. So like prostaglandins, they are contraindicated in uveitis and macular edema. Okay, so what are the side effect profile to be remembered about miotics? Please remember, since they are cholinergics or parasympathomimetics, they will cause spasm of the ciliary muscle. Because of that, there is problem of brow ache or headache. There is pseudomyopia. There can be formation of iris cyst or retinal detachment. Okay, and they also increase the inflammation. So just like prostaglandin analogs, they are contraindicated and in uveitis and macular edema. Okay, and their main use is use of pilocarpine to break the attack of acute congestive glaucoma, right? So these are the points which we must remember about this group of drug. Now coming to your last group of drug, which is your hyperosmotics. Okay, the hyperosmotics, they act different to the three things which we considered for IOP loading. Okay, they are not related by decreasing the aqueous production or increasing its outflow. They act by causing dehydration of the vitreous. Okay, they cause hyperosmosis in the blood, which leads to dehydration of the vitreous and thus decreases the vitreous volume, which also leads to decrease in intraocular pressure. So their mechanism is different from whatever we have just learned so far. Okay, and what are the two major hyperosmotics which are used? One is your glycerol, which is used in 50% concentration given orally. Okay, so it is given orally. The second is your mannitol, which is used as 20% concentration given intravenous. Okay, now mannitol can bring a very high intraocular pressure to normal range within 30 minutes. So it is the fastest intraocular pressure lowering agent. For example, in angle closure glaucoma, during peroperatively, when the pressure suddenly increases and you want to bring down the pressure very fast, then we give intravenous mannitol. Okay, and it brings the pressure within the normal range within 30 minutes. But both of these have multiple side effects because of the action of hyperosmosis. Number one, they, like glycerol, is not good to taste. It causes nausea and vomiting. Due to their hyperosmotic action, they can cause cardiac overload as well as arrhythmias. Similarly, mannitol can cause cardiac overload and electrolyte imbalance. So these hyperosmotic agents are contraindicated if patient has pulmonary edema, renal failure, or right heart failure. Okay, remember the contraindications: pulmonary edema, right heart failure, renal failure. Okay, and which is the fastest intraocular pressure lowering agent? That is your mannitol. Fine. Okay, so just let me introduce you to certain new drugs which are now there available to control the intraocular pressure. Okay, so these are the latest additions. One is your drug by the name of netrasudil. Netrasudil is a new group. It is a Rho kinase inhibitor. The mechanism of action is not very clear so far, but again it has been seen to increase the outflow through trabecular meshwork. Okay, so it increases the outflow through the trabecular meshwork. And one important thing to remember, to be remembered about netrasudil is the one that this can also cause cornea verticillata or vortex keratopathy. Okay, so just like your chloroquine, amiodarone, etc., another drug added for the vortex keratopathy is your topical netrasudil. Okay, then there is a new combination which is available by the name of latanoprostane. It is a combination of latanoprostate and nitric oxide. Okay, and we have a fixed combination of netrasudil and latanoprost also available by the name of rock latin. Okay, latanoprost, Rho kinase inhibitor. So these are the new drugs which are there. So these are your latest advances. Okay, so can we have a quick recap revision with the help of the MCQs? Okay, so please do write your answers in the chat. Okay, so we will revise what we have learned. Okay, right, so let's start. Carbonic anhydrase inhibitors, they reduce intraocular pressure by, carbonic anhydrase inhibitors reduce intraocular pressure by increasing trabecular outflow, increasing serum osmolarity, decreasing aqueous production, decreasing uveoscleral outflow. So what is the mechanism of action for carbonic anhydrase inhibitors? Yes, friends. Yes, absolutely right, Dr. Jiva. No need to put a question mark. You are very right. Carbonic anhydrase inhibitors, they act by reducing aqueous production. And if you remember, what are the other major group which act as aqueous suppressants are your beta blockers. So the drugs which reduced by decreasing the aqueous production are known as aqueous suppressants. Okay. The trabecular meshwork by pilocarpine. Okay, increased serum osmolarity, your mannitol, glycerol, as we just learned. Okay, and uveoscleral outflow, your prostaglandin analogs. And both these are by your alpha agonist. Okay, so that summarizes the mechanism of action of all the major groups which we just discussed. Okay, coming to the next question. Systemic side effects of topical beta blockers include all of the following except. Okay, so in any question I always tell, don't forget the except. Always carefully read the statement. Systemic side effects of topical beta blockers include all of the following except bronchospasm, heart block, reduced exercise capacity, tachycardia. Beta blockers means they are reducing the sympathetic stimulation. They are sympatholytics. Okay, so bronchospasm, yes. Heart block, yes. Reduced exercise capacity, yes. Fatigue, yes. But they does not cause tachycardia. They do not cause tachycardia. They cause bradycardia. Okay, so this is the side effect profile of beta blockers. So they are contraindicated. In second and third degree heart blocks. They are contraindicated in COPD. Okay, and they are also contraindicated in the cases of the asthma. Okay, so these are the major contraindications for beta blockers. Okay, friends. Okay, another question. A 65-year-old man with hypertension and coronary artery disease has been diagnosed with primary open-angle glaucoma. Which of the following is the drug of choice for initiating treatment for him? So systemic history. So whenever we are starting a patient on anti-glaucoma, always ask the systemic history, because we just learned many topical drugs have systemic side effects and we have to rule them out. Okay, so here we have a history of hypertension and coronary artery disease. So what is the drug of choice out of these? Travoprost, timolol maleate, brimonidine, brinzolamide. Okay, so drug of choice, travoprost, timolol maleate, brimonidine, brinzolamide. Yes, friends, what is your answer? Yes, absolutely right, Dr. Jiva. It is travoprost. Travoprost is your one of the prostaglandin analogs. Okay, so please do remember the names of each group, also the major drugs which are there in each group. PG analogs, we have latanoprost, we have bimatoprost, we have travoprost, and the latest one we have tefloprost. So prostaglandin, please remember by this. And as I told you, the first line drug are for glaucoma, your prostaglandin, again your prostaglandin analogs. Okay, here you will not give timolol maleate. in a patient of coronary artery disease, and brimonidine and brinzolamide are your second line drugs. Okay, they are your second line drugs. Okay, second last question. Incidence of retinal detachment is increased with the use of. Incidence of retinal detachment is increased with the use of latanoprost, pilocarpine, brimonidine, acetazolamide. Yes, friends, what is your answer for this? Increase risk of retinal detachment. Which antiglaucoma causes that? Yes, perfect. Pilocarpine, because pilocarpine is causing ciliary spasm, ciliary muscle spasm, due to which there is increased chance of retinal detachment. Okay, so this is typically associated with pilocarpine. Okay, so last question of the session. Which of the following drugs they can cause sleep apnea in children? Travoprost, brimonidine, timolol, latanoprost. Sleep apnea in children. So this was your NEET PG question also. Yes, perfect, Dr. Jiva, perfect, everyone. So it is your, yes, very nice, Dr. Sagar. It is your brimonidine. So that is why brimonidine is contraindicated in children. It is contraindicated in children. Okay, so that brings me to the end of this session, in which we have discussed the antiglaucoma drugs and revise them also with the help of MCQs. So stay tuned for the next session, which is going to be on nystagmus made easy on Christmas, 25th December at 10 p.m. Okay, so all the best, have happy learning, and all the best, my friends. Thank you very much.